We're going to talk to you about septic cardiomyopathy. It's a special interest of mine, but also this department have done a lot of work on this here. Some of you may not be familiar with the term itself, so we're going to talk about it, what it means, and how to look out for it, and how it may affect your, I guess, your practice in the long term. The term septic cardiomyopathy was really coined more recently, but the whole concept obviously has existed for some time. It was initially Linac who noticed that there was weak heart sounds associated with patients who had acute febrile illnesses, and he attributed them to heart failure. Does anyone know who Linac is by any chance?
We know the stethoscope, didn't he?
Yeah, he's the guy who came up with the stethoscope. Yeah, so I won't get to the side as to how he actually came up with it. That's another interesting story. But
I don't know that one.
Yeah, anyways, but he essentially, long story short, he fancied a girl and was a bit shy and didn't want to put his ear on the chest. So that's how he came up with the concept of the stethoscope. Anyways, but over the years, this term has obviously evolved. You know, Janeway, we know from Janeway lesions, referred to, you know, patients who had acute infectious disease and had heart failure. So this concept that really has been around, but it was only in the 1980s that really had a way of measuring LV performance in patients who are septic. And this is usually on nuclear Gerhardy pool scans and cine angiography, where and then subsequently, it was only recently where 2D echo became a tool to identify these patients. So we'll go through a couple of cases. This is case one. If anyone wants to comment on that, chime in. Otherwise, I'll randomly allocate someone. What do you guys see? Yeah, Rishi.
Yeah, so I think looks like at least a moderately dysfunctional left ventricle with normal size. Looks like a bit of apical ballooning going on, with preserved contractility at the base, but definitely akinetic or hypokinetic at the apex to the from mid to apex. In terms of yeah, we are basically a combination of 4-chamber, 2-chamber, focused 2-chamber, and a parasternal long axis fuse.
Yeah, absolutely. So out of those three options, which one would you choose?
It depends on the context, but you know, Takotsubo is always a diagnosis after an angio. And if the patient is, it could be all three of them, to be honest.
Yeah, 100%. You're quite correct. And we'll go through that in a bit more detail. But so you wanted an angio, and here it is. It's going to be a bit hard to see on these images, but if I can try and, can you guys see my mouse just at the ostium there where the LAD, there's this tight stenosis there. Very difficult to see, but I mean, it's easier on the bigger screens. And so this will be in keeping with a ischemic cardiomyopathy. And you're quite correct that it could be all three of them. Takotsubo is definitely on the cards because you got this apical ballooning, or the apex is akinetic. So 100% that's a differential, but you'd have to exclude that based on the angiogram, and that's what we did, and also the clinical context. What did they present with, and other findings as well. So this patient had an angiogram, had an osteo-LAD stenosis, which was subsequently treated and fixed. You're quite correct that this could still also be septic cardiomyopathy. Septic cardiomyopathy, I think, is on a spectrum of also or reversible cardiomyopathy, of which Takotsubo is one of them. Does everyone know or understand what Takotsubo's cardiomyopathy is? If someone doesn't, then just chime up for me, and I'll quickly chime through. This is just a couple of images on the right, just to let you know that the rights are okay. There's no significant stenosis there. So,
Is there a diagnostic criteria for Takotsubo?
yeah, so it's a transient cardiomyopathy. It's usually stress induced, or so it depends on clinical context, and an angiogram which shows no significant epicardial coronaries.
Sure.
Now, Takotsubo's was initially diagnosed on LV ventriculography, so they did LV grams, and you would see this apical ballooning segment or outpouching. And that was really based, I mean, the whole term is in Japanese means octopus trap, because what would happen, they used to have these clay pots that kind of look out where they've got this bell-like pot with a narrow funnel, and they would have it at the bottom of the sea, and the octopus would get in and then would find it difficult to come back out, and you just catch it out. So that's where the term came from, and essentially that's what you would see, but you'd have to have a negative angio to confirm this diagnostically. And usually, what happens is, a third of the cases would happen in patients who are emotionally stressed. So you'd hear broken heart syndrome as an alternative term, and common scenarios is grandmothers or fathers who would be at a funeral, and that's a common scenario. A third of it happens to some sort of physiological stressor, whether it's sepsis, intracranial hemorrhage, or some other medical condition. And a third, we actually don't know. We have no idea why it causes and what happens.
I had one patient years ago, I was at Prince Charles, who developed it after they had their partner arrested, and they did CPR on their partner, didn't survive. And then when the ambulance arrived, she was having chest pain.
Yeah, wow.
And she had Takotsubo. Yeah.
Wow. Yeah.
Full on.
And then you echo these guys a couple of days later or a week later, and the apical ballooning has resolved, so the apex is nice contracting, and that's why you know that this is in keeping with Takotsubo syndrome. So, having said that, Rob, what do you think is going on in here?
The pictures here look similar to the last case. So we got 3, 2, and 4 chamber and a parasternal long, all of them showing what looks to be a preserved function of the basal segments, but then hypokinetic to akinetic apical segments on all walls, which could be, again, it could be ischemia, or could be Takotsubo or septic cardiomyopathy.
100%. And in this case, it was more in keeping with Takotsubo's cardiomyopathy, and that was based on the clinical context. But you are 100% correct in terms of interpreting that echo. All right. Anybody? What's happening here? Who do we have? Sarah, if you want to have a crack.
Okay, so again, you've got a 3, a 2, and a 4 chamber, as well as a parasternal long. I guess looking at the LV, all the segments seem to be contracting normally, as far as I can see. The chamber size in the 4 looks normal, but then I don't know, maybe in the 3 looks a bit odd, but I can't see that wall as well. To me, there's nothing grossly unusual that I can see.
Yeah, I agree. Yeah, 100%. So is this LV function preserved or
Yes,
abnormal or high?
I would say it is preserved to, given that you don't have I don't think it's hyperdynamic, but it's tending towards that end.
Yeah,
of
I think so.
Yeah,
100%. I'd agree. It is not completely hyperdynamic, but it is kind of it kind of looks like it, right? So, but you're right. I mean, this is a normal case of. In fact, that was the case where that patient who had Takotsubo's, the LV recovered completely. So that was, you can see that it was quite a nice example of a transient cardiomyopathy. Hanny or Michael, do you guys want to have a quick go at this one? You can also use the excuse that Rishi used last time, which was the mic doesn't work. Hey, one.
I think LV is dilated with I think there's severe LV impairment, and it's globally impaired. So I can't think of a better way of saying that. But as in, I can't appreciate any regional wall abnormality as such. Harvey also looks dilated, and again, just eyeballing, but the like RV free wall and the tricuspid annulus doesn't seem to be moving well either. So likely severe biventricular dysfunction.
Yeah, I think I agree with you. And in this case, this patient was septic, so the consideration is septic cardiomyopathy. I won't be able to tell you whether this is acute or chronic. I mean, any features that may give you some hints whether this may be acute or chronic, or that you'll be looking into?
I suppose like dilatation, is that a feature of chronic?
Yeah, 100%.
Yeah. I mean, RV dysfunction wise, you could look at like free wall thickness, but can't really.
It's difficult to see in this image. Yeah. Anything else?
And no, that's about all I can think of.
What about the LA size?
Oh, yeah.
So, I mean, you would obviously measure the LA and really have a good look at that and see whether this is dilated. And if it is dilated, it would give you some suggestion that this is a bit more of a chronic element. And then you can also have a look at the thinning of the LV wall thickness, and if the LV the ventricle appears a bit more thinner, then there's another clue. So you look at all the other features to say, hang on, is this acute or chronic? Because as we're going to learn about septic cardiomyopathy, it's the fact that it is acute and it is reversible. Now, it doesn't mean that patients who had previous cardiomyopathies cannot have septic cardiomyopathies. They can still have a septic cardiomyopathy component where their ejection fraction or their cardiac function reduces from baseline, but it recovers to some degree. But that we'll talk about that a bit later on in this talk. So again, it could be any of septic or ischemic cardiomyopathy, but you can see that there is an element of difficulty in terms of coming up with this diagnosis, because there are a lot of it really depends on what was their clinical history and what was their previous cardiac functional or dynamic that determines if this is septic cardiomyopathy. So septic shock we know is one of the most significant complications of sepsis. A lot of you guys would have been dealing with this in your practice. It is defined as a subset of sepsis in which the underlying circulatory or cellular metabolic abnormalities are profoundly abnormal, and as a result increases mortality. Now, in the US, sepsis accounted for more than $20 billion of US hospital costs. Sepsis alone was associated with 10% in-hospital mortality, and if they've got septic shock, it's almost up to 40% or higher in some cases, depending on which papers you read. In some cases, they've even commented up to 60-70%, but it's roughly on ballpark. You can understand that sepsis and septic shock is a significant issue for our patient loads. Now, when we talk about septic cardiomyopathy, we know that the heart is one of the most commonly affected organ, with approximately 40 to 50% of the patients diagnosed with sepsis displaying some form of cardiac dysfunction. Now, sepsis-induced cardiomyopathy or septic cardiomyopathy is defined as sepsis-induced myocardial dysfunction, which is acute, right? So it happens in the short term and is transient, so it is reversible. So it really falls under the umbrella term of reversible or transient cardiomyopathy, and we've got and I think it is part of a whole spectrum of those patients with Takotsubo's cardiomyopathy, including. So I think this is a whole umbrella term that this can be included in. The problem is that there is a lack of agreed definition or consensus. So there's no formal society consensus in terms of how do we diagnose septic cardiomyopathy or what is defined as septic cardiomyopathy. Now, there are some clinical characteristics, and they're usually based on measurements using transthoracic echo to assess the cardiac function. But then the question is, how do you define reversible? In other words, like how quickly does the myocardium reverse? Is it a couple of hours, couple of days, or a couple of weeks? No one really has a good idea of what that means. And and the problem is we're not really that great at following these patients up. I mean, not even with Takotsubo's cardiomyopathy. Yes, we've got Takotsubo's cardiomyopathy. You get an initial echo, but a lot of them won't get a follow-up echo in hospital, particularly not in intensive care. So we don't really know how to what we're dealing with, and we're not really good at following these patients up. And what about those patients who die with septic cardiomyopathy? These guys won't get a follow-up echo. What does that mean? Like, there's a bias in terms of the selection process in these cohorts. So there's a lot that we don't really know about septic cardiomyopathy, and that's makes this whole topic quite difficult in terms of defining it. But there is some expert consensus around septic cardiomyopathy, and it's generally accepted that it is acute, it is reversible. Most of it is based on LV dysfunction, but we know that it can also affect the RV and diastolic dysfunction. Now, diastolic dysfunction in the intensive care is a whole nother topic and a Pandora's box, and I know that it can open up, like a lot of questions regarding that. But just quickly, I can really manipulate diastolic function based on what hemodynamic parameters I want them to have. So if they're depending on what inotropes they have and depending on mechanical ventilation, so I can change the diastology of someone's and augment it really. So it becomes a bit tricky in terms of assessing that. And so, but overall, it is acute, it is reversible, it affects both LV and RV, systolic and diastolic function. So that's what septic cardiomyopathy generally is. It is in the absence of acute coronary syndrome. So in other words, it's not myocarditis. They're not having acute coronary syndromes as STEMI, end-STEMI, etc. And it's also in the absence of other cardiomyopathies. Like I mentioned before, if they've got an underlying cardiomyopathy before, they can still have a transient dysfunction, which then recovers once the sepsis has resolved.
So, Shanthosh, we talk about this being acute and reversible and absence of other features. So we have a patient that has, for example, a viral cardiomyopathy, a myocarditis. They will have left and right ventricular systolic and diastolic dysfunction. With appropriate support, they can have some reversibility there. Are those sorts of cardiomyopathies, are they the same as septic cardiomyopathy? Are they different?
Yeah, they would be probably included in the whole concept of septic cardiomyopathy. And so, you've made a point that those guys may have myocarditis or an element of myocarditis, and I think this is all part of it. And this is all included. The problem is that because we can't define septic cardiomyopathy clearly in the current literature, the prognosis of septic cardiomyopathy is quite poorly understood. We know that, actually, interestingly, we know based on the retrospective and prospective data, patients who had sepsis and had acute LV dysfunction didn't really have an increased mortality associated with. This I thought was quite interesting because we know that LV dysfunction generally, whether it's post-myocardial infarct or any of those cardiomyopathies, they do poorly compared to people who've got normal LV function or hyperdynamic function. So in the septic cohort, people who have got acute LV dysfunction, their mortality isn't increased compared to other parameters. And it is thought that this may be due to a compensatory mechanism where to reduce myocardial demand on the heart. So I guess watch this space. But on on the other hand, the guys that had diastolic dysfunction, they actually had worsening mortality outcomes, as well as the guys who had right ventricular dysfunction and sepsis. It was also associated with worse long-term prognosis, particularly in the first year. So you've got this, group of patients who are septic, who've got some sort of cardiomyopathy. We don't really know how to define it, or we kind of think we know, but we're not really consistent across the board. So a lot of us look at a whole number of patients when we talk about septic cardiomyopathy. Is it just purely viral? Does it include the guys who are bacterial? What about all of the other cohort or population? So it makes this population quite difficult to understand and study. And so that's what our unit here is looking at in terms of moving forward to, get a better consensus and an idea of what we're actually dealing with in terms of septic cardiomyopathy. When we talk about septic cardiomyopathy, it is based on a whole lot of different pathophysiology. We know that there's oxidative stress and reactive oxygen species, which can impair protein function and the general function of the myocytes. A lot of it is thought to be mitochondrial dysfunction. So this the circulating septic sepsis itself releases toxins which kind of blunt the mitochondrial function itself, and as a result, it impairs the myocardium and the function itself. And as soon as those toxins are removed, the mitochondria is actually pretty good at recovering, and therefore the myocardium recovers. So it's thought that that's one of the mechanisms. It is also thought that the coronary circulation, particularly the microcirculation, is just absolutely bombarded by these toxins, and therefore you trash the circulation. There's a lot of edema and so forth, so there's slow flow or slow coronary blood flow, and therefore you've got reduced myocardial function. So there's a whole host of different ways of that septic cardiomyopathy is thought to have occurred. And again, because we don't really know how to define it, we don't really understand what the pathophysiology is, but there is some work on it, particularly around the globe in terms of this, or in terms of really understanding the mechanistic processes of septic cardiomyopathy. Like I said, there's many different theories, but the problem is because we don't really know or understand, it really impacts on it. Well, how do we manage these guys? Do we just control the sepsis and forget about the rest? Do they need to be on an ACE inhibitor or some sort of cardioprotective agent?
Beta blocker.
Or a beta blocker.
Like, if we're talking about microcirculation, the myocardium has to work harder. Calm myocardium, because of the edema, just reduces myocardial demand, right? So the heart rate down, beta blocker.
Yeah, but then someone's going to argue, if they're in shock, are you really going to give someone beta blockers?
Yeah, so, different discussion again, isn't it?
Okay, so it is quite difficult. So I don't know is the answer, or is the bottom line. So, but there are different mechanisms that are contributing to this. So this is just to show that there's been a lot of work, including, Sam Orde there, who's done some stuff on this. And there again. Anyways, so moving forward, really, septic cardiomyopathy, it is acute, it is reversible, it affects both LV, RV, and diastolic function. Recovery is usually 7 to 10 days in most literature, but having said that, I've seen someone 3 months down the track and their LV has recovered only then, whereas I've scanned them 2 weeks after and their LV still hasn't recovered. So I think it can vary, but generally the accepted expert consensus is that it usually recovers within 7 to 10 days, or at least once the resolving sepsis has resolved and the toxins have been cleared. So it really depends on. One of the things is timing of the echoes. When do you do it? In terms of the intensive, like when we're in intensive care, do you do it at the time they hit ED or ICU? And we know that sometimes there can be a delay up to 24 hours when they hit ICU or whatnot because of logistics. And by the time the sepsis has already started to clear and the patient's better, and did they have septic cardiomyopathy? I don't know. And when do you do the follow-up echoes? And there's also a selection bias. A lot of these guys, some of these guys are quite sick, as the mortality is high. And if they've got an LV dysfunction who are, down to 20 or 30%, and they subsequently die for whatever reason, did their LV at least recover at all? Do we know what happened to the RV? I don't know. And so we know that the guys who've got acute LV dysfunction kind of do better. RV dysfunction, not so great. Diastolic dysfunction, again, have worse mortality.
Because it can be LV and or RV and or diastolic.
100%.
1, 2, or 3 kind of.
Yeah, exactly right. So just another slide, just to say that there's a couple of papers that talked about when septic cardiomyopathy that had a U-shaped curve. So the guys that have acute LV dysfunction and the hyperdynamic group, interestingly enough, also had worse outcome or mortality. So there's this U-shaped relationship. So sometimes you see these guys, you put they're septic, you do a quick echo, their LV is really clapping away, and that's also deemed to be bad and that have an associated increased mortality. We talked about briefly, what about if those population who had a pre-existing cardiomyopathy? Now, again, this is quite difficult to study. It really depends on what the baseline echo is. If they've got moderate cardiac dysfunction with an LVEF of 35%, we really look at what the delta change is in terms of their cardiac function. So it may have gone down to 25% or even less, and then you do a follow-up echo and see whether they've recovered to their baseline. Sometimes we don't have that information. They've come on from somewhere else, and you really have to base it on their history in terms of they've got cardiac failure or heart failure in their history, they're short of breath, have orthopnea, PND, or you'd find that they're on medications like Entresto or dapagliflozin, so SGLT2 inhibitors and beta blockers, etc. And so you piece together and say, oh, look, this patient probably had some sort of cardiac dysfunction in the background, and their ejection fraction has now deteriorated even further. But the key is that they usually recover back to baseline once the sepsis or the offending agent has resolved. So, and this is, we always base this on or excluding other causes and ensuring that these guys don't have any ischemic conditions or other comorbidities that can contribute to the acute dysfunction. Does that make sense so far? Right. So let's talk about a case. This case actually happened this week. You probably know this patient. 63-year-old female with right lower quadrant abdominal pain and dysuria, was nauseous and vomiting. She presented to the ED, had a CT KUB done, and it showed that she had some perinephric stranding on the right with moderate right-sided hydronephrosis, mild hydrourethra with periureteric stranding, and they identified a 4mm calculus in the distal ureter. And so the conclusion was that this was an obstructing calculus, and so this patient can be managed with antibiotics and just wait for this patient to pee. They were sent home from ED on the advice of the urology team. This is in the background of past medical history. She has hypertension. She's actually was relatively active. She plays soccer for a social comp. And everyone's smiling because when you look at her, she didn't seem to be the type that was quite active, or in terms of like quite physical active. So I did ask her what position she played, and she usually plays soccer. So she plays goalie. So they thought it was pretty funny that I asked this question, but I thought it was curious. But anyway, she's active. So what I'm trying to get at is she doesn't have any history of heart failure in her history. So she came back after a day, I think, with lethargy, worsening fevers, hypotensive. And so she was taken to the operating theatre, and she had a stent inserted into the right ureter. And she was transferred to ICU for increased inotropic requirements. Her CRP was high, 310, white cells were 25.5. Her urine MCS has come back with E. coli, and she was also oliguric with metabolic acidosis. So in summary, she essentially had urosepsis secondary to a right renal calculi, and she was commenced on tazocin. She was oliguric with an acute kidney injury. She had 5 liters of fluid in ED. Creatinine was 350 and her baseline is 105. And she was persistently hypertensive, requiring inotropes. So what would you do with this case? do you just continue treating her for urosepsis? Just do you start dialysis, or would you do something else? Anyone out there? Thoughts? Rishi, since you're intensive care.
Yeah. Yeah, so yeah, definitely. I think treating the urosepsis is the bottom. Definitely will do it. That's the first thing. Controlling the source. Maybe trying to speak to surgeons to get a source control.
Yeah.
That will be the top of my cards. Second, regarding dialysis, it depends. It depends on whether she's I'm doing it for fluid overload, or she's severely acidotic, or very hypokalemic, then that will be my triggers for dialysis. Or what's the overall trajectory I'm looking at, whether I should benefit from early dialysis to get on top of the acidosis or the fluid balance. Other investigations I'll start with definitely a transthoracic echo to look at the cardiac function, the filling status, and having a look at the lung ultrasound to see whether she's exhibiting signs of pulmonary edema as well.
Yeah, 100%. I mean, if her urosepsis, I mean, you've got kind of source control. I mean, you've got a stent in, she's on antibiotics.
I got a stent.
And has reasonably high requirements of inotropes. Her blood pressure is still 80. Would you guys normally do an echo? Or would you just hang tight and just see how she goes? Just out of my curiosity.
It depends on what geography and what unit you are and what facilities you have.
Yeah, 100%.
Yeah, and also it's a bit unusual, the degree of renal failure for simple urosepsis. You wouldn't see renal failure requiring
that extreme.
Yeah. So yeah, I think our threshold for doing echo will be a bit lower.
Yeah.
Yeah.
So I think, I mean, Rishi and Hewan have just, 100% pointed out. But in fact, this patient wasn't due for an echo at all. I think they were just going to manage this patient and just wait and see, and see how it goes. So I stuck my, neck in, or not neck in, I was just curious. And so this is the initial echo that she had. Rob or Sarah, do you guys want to have a quick comment on this?
LV function looks to be hypokinetic, kind of within kind of all segments, really. I think, like, maybe not so much the basal segment, certainly the mid and the apical segments don't look like they're contracting effectively.
Yeah, 100%. Which I thought was quite curious. So, sorry, the images aren't great, but 2 and 3 chambers.
Yeah, again, I think in the 2 chamber, kind of just looks like it's sitting there. And I think maybe the septum is contracting more effectively than other components in that 2 chamber view. But yeah, looks abnormal.
100%. So if you had to give a ballpark figure of what the ejection fraction is, what would you say roughly?
30%?
Yeah, I would agree. So 35%, I 100% agree. And I think there's something that you mentioned. I mean, you said that the lateral wall, you had difficulty seeing, or you can't see all of the segments. Is there anything that you could do to try and optimize or see the walls a bit better?
As in while you're taking the pictures, or in terms of post-processing?
Either.
So in terms of post-processing, I guess I could try and put on a color map to see if I can see like endocardial borders better, to see to appraise contraction. In terms of at the time, again, trying to increase the resolution, so you could decrease the sector width here. If you're just looking at the LV, you can use dynamic zoom to try and just focus on the LV rather than including the atria. And yeah, again, like a color map would be the ones I would think of.
Yeah, absolutely. And what about anything else that I could administer?
If you were concerned, you could give some contrast, some
Yeah,
definity or
100%.
something.
Yeah, exactly right. So if there's ever a concern that you can't really see the endocardial borders well, you'd definitely consider giving contrast. And I think, to be honest, in this case, I would have really considered that if I didn't improve it, because having a good idea what the ejection fraction is really helpful, particularly in terms of clinical management for this patient. But you're quite correct, Sarah and Rob, and those are the things that I would have made adjustments to. The only thing I can't really make a difference, I'm not sure if Haywan or Ben or anyone can comment, is on that 3-chamber where my mouse is, there's a hyperechoic lesion that's on that lateral wall. Like, what is that?
Lung,
So it's just that some chunky lung bit?
patch of consolidated lung. I think so. I mean, it's a bit hard to say for sure because I wasn't taking pictures in real time. But what it looks like, you've got, so coming in from the left side of the sector, I'd be suspicious that you're getting, it's a little tail of lung. I think at the very top of the sector where the lung meets the apex of the heart, you've got a small amount of subpleural consolidation because you've got a slightly irregular line where the speckle's starting to form.
Yeah.
And then you've got a little blob of consolidation or interstitial change there, which is giving off, it's a nice little speckle of B lines that are coming off there that are dynamic, right?
You're talking about these white lines
exactly
that
right. Yeah.
like
So I think you've got
strobe lights?
Exactly, like I explained it like a spotlight, right? It just goes over everything. So I think that's, it could be a tag of pericardium or something, maybe, or pleura of visceral pleura, but I said it's lung.
But it is moving up and down with respiration. So yeah. But the reason why I was pointing that out is, I mean, we are looking at, the LV and whatnot, but it's quite important to make sure that you look at the whole image and pictures, particularly for your exams, and so that you don't miss anything that's outside, particularly if you're doing subcostal views and whatnot, and you see some liver cyst or mass and say, hang on, what is this?
Yeah.
Or there's something on the IVC, fusions, exactly right. So it's quite important to include all of that. So yes, Rob, can you comment on the still images?
Sure. So in the top left-hand corner, you've done a RVOT VTI, which looks like it could have been taken subcostally or from the parastitial. I can't see the pictures too small, but
short, but yeah.
Yeah. Which is significantly reduced. I'd optimize my spectral Doppler picture so I could trace it accurately, but regardless, it's significantly reduced at 6.6 centimeters.
So you're 100% correct. So just before we move on, you said you're going to optimize that. How would you do it? How would you optimize it?
Feel free to criticize Shanthosh's pictures as much as you like as well, by the way. I'm guessing you took this.
I've got a comment.
So you need to adjust. Firstly, I adjust my baseline up a little bit. I still want to see I would still want to see if there's any reverse flow, but I'd move the baseline up a little bit, and then I'd optimize my velocity scale so that I can have it having at least two-thirds of the image below the baseline and trace it accurately. Otherwise, it looks like a good trace. Otherwise, I can see the closing click, but not the opening. So it looks like it's probably in the right spot.
Yeah.
But like I said, it's significantly reduced. Next image is across the LVOT, and I would also for both of them, it's been blacked out, but for both of the images, I'd change my sweep speed to at least 100, so that you can trace it out accurately. But this one is also significantly reduced at 11.3 centimeters. The next two images are looking at the longitudinal function of the right ventricle, and both the TAPSE and the RVS prime is significantly reduced. So I guess to summarize, the cardiac output is reduced, and you can see that the longitudinal function of the RV is reduced. And we knew from the 2D images that the LV function was significantly reduced.
100%. And even Sarah mentioned, look, the RV may have also looks like it's reduced. So the TAPSE shows that the longitudinal function of the RV is also reduced. So you were quite correct. So piecing it all together, you've got biventricular dysfunction in this patient of at least moderate significance. So couple of days later.
Oh, nice.
Sarah, and what do you notice in this case?
Okay, so these
Andrew,
are
Michael, or Hanny, feel free to chime in if you want. Yeah, go on, sorry.
for a parasternal and parasternal short, or a long
Yeah.
and short. I guess in terms of the LV function, comparing it to the original images, it looks like there's been recovery of biventricular function. Both sides appear to have improved in function. All segments of the LV seem to be contracting more effectively. The RV, just looking at that tricuspid annulus, looks like it's moving more compared to the indices that we saw in the previous slides. And it looks like the left-sided chambers are of, normal size.
Yeah, 100%. And it's really coming down, right? So in this case, if you had to give a ballpark EF, I know you said 30, 35 last time. What about this time around?
I'd say 50, 55.
Yeah, I think so. You're 100% correct. So it has recovered, right? And Rob, what about the, in this case, the RV function and the VTIs?
Firstly, I'd say the spectral Doppler optimization has improved significantly. but looking at so I guess the RVOT VTI, the value is still low at 8.5 centimeters, and it looks like it's been well traced. However, the LVOT VTI is within the normal range, and the longitudinal function of the RV is now within the normal range for both TAPSI and RVS prime.
Yeah, 19 and 0.12, so 100%. So this is again keeping in what you saw on those 2D images of the LV and the RV, that the function overall has improved. So this patient is making a great recovery. Both the right and the left is recovering, and the sepsis, from what I can gather, is improving. So this is quite a cool case, and I think this is quite a cool case of septic cardiomyopathy of a patient that is recovering. You still have to, follow this patient up and make sure that they don't have any underlying, coronary disease that may have contributed to this. But at least based on the clinical diagnosis, this will be in keeping with septic cardiomyopathy. Does that make sense, everyone? Happy with that? Any questions, concerns, doubts? No.
Let me just ask you quickly about, how I mentioned diastolic dysfunction with septic cardiomyopathy is bad.
Yeah, bad, yes.
But it probably reflects my poor understanding of diastolic dysfunction. But I read somewhere, if you have systolic dysfunction, then like by definition, you have diastolic dysfunction. Is that?
Yeah, 100%.
But when you say diastolic dysfunction is independently associated, does that mean like you have to have independently abnormal diastolic parameters? Is that what you mean?
Yeah, you'd have to have some sort of so you can this is in the cohort where you've got normal LV parameters and they've got diastolic dysfunction or abnormal relaxation.
Yeah.
And so in those cohorts, they found that the mortality was actually higher.
Okay, all right.
Preserved systolic function, only isolated normal diastolic function.
Gotcha. All right.
Yeah.
Okay. Thanks.
Which is a pretty niche cohort, really. Like, if you
Yeah.
get the patient, if they're going to be sick enough that they've got septic cardiomyopathy and they've only got,
Diastolic.
and that's where it comes back to definitions, right? Like, how do they define these patients and find them in the first place? You put it for a name, and everyone in ICU is going to have diastolic dysfunction.
100%.
Just everyone.
Yeah, and the problem is that a lot of these papers didn't actually talk about all of the other parameters that you can augment diastolic dysfunction. So how much inotropes were they on? What was a PEEP?
Yeah.
All of these things. So there's a lot of asterisks around these things. So yeah, but yeah, that's why it's a bit messy. But yeah, I hope that makes sense. I hope I've kind of convinced that septic cardiomyopathy is an entity. It does exist, and you'll find it in your population out there. So yeah, that's pretty much it. Thank you, guys.
A question.
Yeah.
So, what's the role, if any, in strain and speckle tracking in septic cardiomyopathy? Because like looking bigger picture, things like cardio-oncology, obviously that's like the study that's done now is you're doing everyone looking at strain and different forms of strain and speckle tracking. And it's becoming more and more, it appears to be a more commonly done tool. So is there much out there regarding that?
There is, yeah, 100%. So what Ben's talking about is using strain or global longitudinal strain to assess subtle myocardial dysfunction, which you can't really see on your gross Simpson's biplane measurements of the LV, and really you will see that there is a element of dysfunction in this cohort or reduced GLS with preserved LV function, but the GLS is down and they have an increased mortality associated. So, you know, where we were talking about where the population where the LV is preserved and they've got a reasonable outcome. In that group, the GLS is likely impaired, and there's groups that are studying that, and there is data on that. But again, the cutoff parameters. So normal global longitudinal strain. I know Sam's going to talk about GLS or etc. down the track, but normal LV global longitudinal strain is between -18 and -20. -15, 14 is where you get really abnormal dysfunction. And I'm talking about the deformation or the contraction of the myocardium in all directions. And the studies out there again have used varying parameters of, like, you know, or cutoffs. So again, we're not comparing apples to apples, but there is work on that, and there is also work on myocardial work in terms of how that can be extrapolated.
And I guess another follow-up question in a way is that we can use ultrasound contrast to look at like coronary flow and some of the smaller vessel flow in the heart when you time it right. And if this is potentially a disease of the microvasculature of the heart, we've got evidence now that you can give contrast and you can use sonothrombolysis in coronary artery disease, acute coronary syndromes. What about using that in treatment for this? Could you give contrast and burst the bubbles and then see if that makes a difference? Has that been considered?
It has been considered, but no one's done it yet.
Right. Okay.
In fact, we were thinking of doing it at our unit here, but it is a watch this space. So this is stuff that Ben is talking about is relatively quite advanced, which will not be covered in your DDU games. So just out of interest. So he's talking about using those contrast agents that we use to opacify the LV. So, you know, we use Definity and whatnot. So if you can destroy those bubbles and replenish the circulations to a degree, or improve the microcirculation. So he's talking about, can you do that to improve the cardiac function? This is all theoretical at the moment. We don't know. So I hope that makes sense. Anyone else?
I had a question, if that's okay. I didn't catch whether you altered the management after the first echo, and I asked that question because I think a lot of these patients probably do go missed because, you know, they've got urosepsis. You sort of don't have a reason to do an echo. They're on a bit of NORAD. That NORAD comes down over a few days and they get better, but they may have had a septic cardiomyopathy during that period. In this patient specifically, did you start an inotrope or did they just get better with time?
No, they were commenced on dobutamine after that echo. So, and then weaned off on the inotrope, like the NORAD. And that made a big difference for them. So it did make a difference in terms of the management and also understanding as to what was going on.
Yeah, thanks.
One last question, actually. So a big component of this is excluding like coronary artery disease. You know, they have to have no other reason. And people have NSTEMIs, for example, like they may all have, you know, some regional motion abnormalities, and that will get better over time, troponal gut, whatever. But it seems to be fairly uncommon that these patients would do things like get taken to the cath lab, especially when they're pretty sick. So the idea of excluding coronary pathology, just to call it septic cardiomyopathy, is that just again, a bit of a vague way of saying it's the people that are at the end of the bed looking after the patient who feel confident it's not a primary coronary event? Is it?
That's correct.
Yeah.
Yeah, 100%. Because as you know, like any coronary event can cause cardiac dysfunction or regional wall motion abnormalities. And we know that acute coronary syndrome is associated with increase in mortality. So it's at the end of the bed saying, hang on, is this patient actually having an infarct in front of me? And is this what's happening?
Yeah.
And excluding that based on your history, ECG and findings. But you're quite correct. I mean, these patients can be quite sick and unstable. That sometimes when they're in septic shock, and also we don't want to instrument anything in the heart when they're in septic shock. So we kind of just wait or let it recover. Unless they're having a STEMI, then you're forced to do something about it. But if they're stable, once they're stable, then you can reassess and think about doing that. And it may be as an outpatient where you just, if they've got no symptoms of angina or whatnot, or ischemic changes on the ECG, you may just hold off and just do a CT scan, CT coronary angiogram, or even an angiogram down the track electively or semi-electively. Yeah.
Okay.
Cool. That's quite useful. Thanks, guys. Appreciate it.
That's fine.
Appreciate the questions. Not a problem.
Thanks,
You're most
Shanthosh.
welcome. See you next time.
Thank you.
Thank you.
Thanks very much.